So we have the privilege of doing the last session of today. We thank all speakers for keeping time, so we will have some very interesting questions to answer. So we start with the first presentation, which is comparing the three laparoscopic techniques for indirect hernia surgical repair in children, a single-center experience, presented by Chiara Colecchio from the Grande Institute.
Can you go? Yeah, sure. Yeah.
So we start with the third one. So we go to the next one, we'll have her back. Yeah, that's not really. We go to first results of pediatric robotic inguinal hernia repair with the 7 months robotic system, presented by Roxana Eurling from Maastricht Hospital in Netherlands.
Good evening, everyone. Thank you for the opportunity to present our first results with the Senhance robotic system for inguinal hernia. So far, 14 patients have been operated using the system, mainly male, and in total it accounts for 19 inguinal hernias. During the procedures, 2 times there was a problem with the robotic system for which the contralateral side had to be done with the conventional laparoscope. And otherwise there were no in-hospital complications and also no post-operative complications except for one recurrence in an older patient that was already 16 years old when he was operated on. So in his reoperation he received a mesh replacement. In our experience, the Senhance robotic system was very, very safe and effective for inguinal hernia repair. The open module setup with the different arms is very nice for communication with the team and the surgeon. Some alterations had to be made logistically with placement of the trocars and stuff like that, but that comes with experience and it goes easier over time. So in our experience, it's a good and safe method for inguinal hernia repair. Thank you.
Any questions from the floor? Yeah, we have questions. Can you take the mic? Yeah.
Do you need to change your operating room for the Senhance surgery?
Yeah, the robot has to enter the room and it takes a while to set up the system and dock the system as well, but that also comes with a learning curve, so it goes faster.
Normal OR.
Normal OR, yeah, just you drive it into the OR.
Any other question from the floor? Can I ask a question? Do you have normally you do all hernias laparoscopically in your center?
Yeah.
Did you change the technique because it's
No, the same technique was used like an intercorsal first.
And did you do special selection on the patients? Or just...
No, it worked 14 consecutive patients.
Okay, thank you.
What was the average time taken by the robot?
The net operating time was, I think, 42 minutes, and then docking of the robot took up on average, I think, 10 minutes. So it was on average an hour for each operation.
Thank you.
Do we have a presentation of Chiara? Is that okay? Can we move to the next one?
So the next one is laparoscopic common bile duct exploration in a 14-month-old premature female from Greece.
Greetings everybody from the Association of Hospital of Athens. We present the case of laparoscopic common bile duct exploration in infant, an operation that comes with higher stage risks, mainly due to comorbidities, and needs advanced laparoscopic skill. Prolonged learning curve is mainly due to rarity even for referral centers, and in our case, we had the assistance of a high-volume laparoscopic duct surgeon and expert on intraductal laparoscopic surgery. Still, it took multiple attempts and multiple catheters in order to be able to perform an intraoperative cholangiogram that was fortunately without feeling defects. Patient was discharged on the third postoperative day, and 6-month follow-up is event-free. Recapping on our technique technique and the method that we chose, we concluded that one-stage surgery is the best option for any patient, and this operation is proved in literature to be safe and effective. But still there is a need for instrument utilization according to age and size in order to be able to reproduce the technique and wider adaptive. Training is always the best way to improve our surgical skills, and shared knowledge will help with that so that we improve our surgical and clinical outcomes. And what we've noticed in our hospital is that advances in neonatology care are expected to increase the cases that will need the laparoscopic common bile duct exploration, so that we feel we need to be prepared. Thank you.
Any questions from the floor? Can I ask anybody who does this technique with compressed on a regular basis? Thank you. Anybody has done it before? Or a case like this? So in adult surgery, they do it very often.
In Athens, we have the help from an adult surgeon that they do it more often, for sure, than we do. But there are many cases right now that are under active surveillance, so we think that we will have more cases in forthcoming future that we need exploration.
If it's difficult to put the catheter inside of the common bile, you can just make a little opening onto your gallbladder itself and then use that.
As the ground, yes, with the ground system.
Thank you.
Thank you. We have the next presentation, Indocyanine green fluorescence guided laparoscopic surgery for cardiac in biliary atresia. Jay Kumar.
Good evening, everyone. I will be presenting a case of biliary atresia where we performed Kasai procedure with the help of laparoscopy and under the guidance of indocyanine fluorescence. My patient was a 4-month-old boy who presented with features of cholestatic jaundice. On examination, he had ictus and was malnourished. Further investigations revealed direct hyperbilirubinemia, while the investigation suggested a small gallbladder with no intrahepatic biliary radical dilatation. A HIDA scan was done which showed absent drainage even after 24 hours of the radionuclide injection. We proceeded to perform the laparoscopic surgery. 24 hours before the operation, we administered indocyanine green and we used Karl Stoll's Rubina system for the operation. Here are the port positions where we used 4 ports, and intraoperatively we found that the liver was patchy. It was having a patchy fluorescence. And the gallbladder was not fluorescing, implying that if indocyanine has not reached the gallbladder, it suggests again that it could be a biliary atresia. While the contents of the gallbladder were here, we further proceeded for the dissection. Here we can see that the gallbladder is being mobilized and it is not fluorescing against the fluorescent liver. And once we completed the dissection, we prepared the porta. Here we can see the fluorescence in the portal plate, suggesting that we have reached the adequate depth during the dissection. Further, we extended that umbilical port and prepared the jejunum for doing the anastomosis. Here, the loop was brought into the porta hepatis and we performed the anastomosis of portal enterostomy of the posterior layer. But due to the intraoperative difficulty, we had to give a subcostal incision and complete the surgery. Post-operatively, the patient had an uneventful recovery, and at 6 months, this is the appearance. He had a normal healed scar and he was thriving, passing Colex tools. To conclude, indocyanine green helps in functional assessment. It can identify vessels intraoperatively and also helps in identifying the adequate depth of dissection in the porta. And it also has the benefits of laparoscopy, that is smaller incisions, magnification, and early recovery. Thank you.
No question.
No question? Then we go to the next.
We'll move on to the next.
Next presentation is single port cholecystectomy using conventional laparoscopic instruments. Is it feasible? Right? Moreno Alfonso from
single port cholecystectomy. As an introduction, we would like to specify that this procedure requires specific instruments. Of course, you have to consider plastron and lateral triangulation. When you use specific materials that are designed for it, they are costly. And well, we wanted to share some technical strategies and modifications that enable us to perform this procedure with homemade resources. For example, here you have the technique of the instruments that we use with frequency, and also a Kirchner needles, which we use to establish a traction from the gallbladder in order to dissect the triangle. Also, you have here the cosmetic result. We use our single port surgery in our center, and we are used to use Alexis and the lot as a homemade single port. And although the lack of triangulation, it works quite well in this situation. Regarding our patients, we have 5 patients. Our conversion rate was just 1 patient, 20%. The median operating time was 145 minutes. The median hospital stay was 40 hours. The opioids improvement was low. We didn't have any kind of complication, and when comparing the procedure cost with the 3 ports or 4 ports slot, we did not find a significant difference. The cosmetic result, as you see, is quite good. And we have to consider this is a complex procedure that should be performed with people which has experience in single port, but it's feasible even in a low volume centers. Thank you very much.
Any questions? Any questions?
I'm doing everything in Singapore for just a minute because I'm working since I was 63 disease. I have more than 165 just cooling. Actually, you have to be very cautious about colposectomy cells because I have 2 avulsion. If you're using my TV, just about cystic duct from the common writer. I was lucky in one I could put a clip, the other one I had to wear the CBD. So the fraction with the I'm using normal instrument. The fraction with the clashing with the normal instrument itself is very, very dangerous. I can do screen without clothes. I don't care about screen, but I care about the cooling cells. So be very conscious.
Yeah, for sure. We use the Kirchner needle, and for us it works well because the fraction is constant. We didn't have any problem, but of course we have to consider it also. Thank you.
Thank you. Thanks. So the next one, okay, easy endoscopic treatment for Burke-Klopfler syndrome by Ziada Gavan from Spain.
Good afternoon, everyone. I'm going to present a case of a 15-year-old patient with spastic paralysis who was carried orthopedic since he was 4 years old. Due to the development of severe scoliosis, we have to perform a new PET, and in the first postoperative week of the she began presenting pain with the nutrition and the output of a periostomy of the diffuse material. Given the suspicion of the Barry-Bamber syndrome, we made an exploratory gastrointestinal endoscopy and sedation in the pediatric intensive care. Like you see in the images, the diagnosis was confirmed, and with the manipulation we saw there was a way to the wall to the gastric lumen, so we decided to make the change of the device using a guide wire like you see in the picture. The procedure was uneventful, and the patient was discharged the same day using the device.
Questions from the floor? Do all your patients get a balloon, like a push technique, gastrostomy from the beginning?
No. For the first gastrostomy, we made full, and this patient was half a bumper.
Next presentation is comparison of 3 laparoscopic techniques for hernia surgical in children, single center experience.
Okay, good afternoon. We solved the technical issues, and today we would like to present our work regarding the comparison of laparoscopic hernia in children. And as we know, it's a very common condition that can be approached via many different methods. The aim of this study was to compare three techniques that are the percutaneous inguinal suturing, the laparoscopic inguinal hernia inversion and ligation, and the laparoscopic inguinal Z suture, intracorporeal Z suture. We included 62 patients, and the treatment of choice was decided according to the surgeon preference and experience. And we evaluated the parameters that you see on the screen. Our results were that there were no statistically significant difference in any of the parameters considered. We want to stress the fact that the rate of recurrence and relapse is almost negligible for all the techniques, besides the Pierce one, that however is also the most recent one and the one we are least used to perform. And we also want to stress the fact that even though our pool of patients was restricted because we were only 62 patients, we still had a statistically significant difference in the fact that laparoscopy was able to detect bilateral inguinal hernia that were preoperatively diagnosed only as monolateral. So we stress the fact that further studies are for sure required in order to confirm the fact that those techniques are comparable. But this is, of course, a good starting point for the future of laparoscopic hernia repair in children. Thank you very much.
Do you have any questions? Another question? What technique would you prefer?
I would personally prefer the inversion and ligation technique because I think it's time sparing, and also because if you can avoid nothing or anything that may damage surrounding structure, maybe it will be better if you're not yet comfortable with the use of laparoscopy. If instead I was an expert of laparoscopy, probably I would prefer the Pierce technique.
Thank you.
We have the next paper from France, predictive factors of complications and post-operative recurrence of fundoplications in children, about 160 cases.
Presentation got cancelled. The next presentation is the gastric trichoepithelial, the laparoscopic technique for gastric hesitation. Maria Lola Blanco from Madrid.
Good afternoon. Trichoepithelial and digestible mass of hair, and the main complication of its surgical treatment is the chemical or bacterial peritonitis. So we present here the laparoscopic technique, in which we use a bag with a rigid body fat capture type ring that we introduce into the stomach through a gastrotomy, so we minimize the peritoneal contamination. So we place our 10-year-old patient in a supine position and using 4 trocars. We do a gastrotomy in the anterior gastric phase. Then we introduce the bag from the most proximal part, the fundus, and then with the back and forth movements, we manage to enroll the whole trichoepithelial. The movement is towards the pillows. So then we close the bag, and then we open the bag through the umbilicus, and with the help of scissors, we fractionate the viscera. The gastrotomy, we close it with a suture resorbable and barb, and then the patient was restarted enteral nutrition after 24 hours, and then she was discharged after 3 days. And after 4 years of follow-up, she is asymptomatic with no other complication. Thank you.
Any questions? We'll move on to the next presentation.
Yeah, it's laparoscopic removal of a large trichoepithelial in a 10-year-old female presented by Rivasi Menon from India.
Good evening, everybody.
they compose of ingested hair. It's a rare disorder which is seen in adolescent females, and they usually present with an abdominal lump or with features of obstruction. We can remove the trichobezoar by endoscopy, laparoscopy, or by laparotomy. Our patient was a 10-year-old female who presented to us with pain abdomen and a palpable lump in the left hypochondria. She was diagnosed with a massive gastric trichobezoar on ultrasound. We had given a trial of removal of it endoscopically, but we were unable to retrieve the specimen, so we had to go for laparoscopic removal. With the patient in a supine position, we had a 12 mm infraumbilical cavernous port with 5 mm ports at the right and left flank side. We did the gastrostomy. We were able to extract the bezoar by sort of peeling the stomach of the bezoar slowly, and once we had retrieved it, we placed it in a glove bag. We proceeded for the repair of the gastrostomy that was done in 2 layers. The inner layer with 30 PDS and the outer layer with 30 V-lock suture. The patient had tolerated oral feeds well by second post-operative day. We were able to discharge the child successfully by third post-operative day. She remains asymptomatic on follow-up, and we made sure that we referred the patient to psychiatric clinic as well for counseling. Below is the intraoperative image of the specimen retrieved, which was 10 by 6 centimeters. We were able to extract the specimen by extending our infraumbilical incision slightly. So in conclusion, we can say that laparoscopic removal of trichobezoar is safe and it is effective without spillage. We should also make sure that we get appropriate psychiatric referral for these patients as well in the post-operative period. Thank you.
Thank you. Short question? You can stay on the stage. Next presentation, laparoscopic assisted colonic culture. Sorry.
I asked the question for the 2 presentations. Do you know any alternative treatments?
Any alternative treatments?
Alternative treatments can be dissolution of the bezoar, enzymatic dissolution is one alternative treatment that people do consider.
With what?
Propofol.
Exactly.
Another question?
I would like to suggest something also very important. We know that exists Rapunzel syndrome. It means that trichobezoar in stomach, it's not necessary to be only in stomach. It can be in distal part of the gastrointestinal tract, and it means that it's necessary to check is the product below the stomach.
How do you check?
Control normal exploration with movement of light for the mechanical people in the same attitude.
In the first case, we did an endoscopy before, and we couldn't see that Rapunzel syndrome. But you have to study very well because you can only extract like this when there is no Rapunzel syndrome. There is no extension of the trichobezoar down the fibrous.
It's necessary to check because sometimes it can be in one shape, but also it can be in several parts of the trichobezoar.
Thank you. We'll move on with the next presentation.
So the next one is laparoscopic assisted colonic pull-through inside core pouch colon for the CT.
Type 4 pouch colon is quite rare disease, but there is good incidence of this case in India. Our patient is a 2-year-old female. She is a case of anorectal malformation with type 4 pouch colon. The anorectal malformation she presented because of the vestibular fistula. She had underwent an operation prior to her presentation to our hospital. That was resection of the pouch colon and an end colostomy. And once we had evaluated the patient, we took her up for laparoscopic assisted pull-through of the colon. So, we were able to take down the stoma using our endostapler. We proceeded for mobilization of the descending colon. We were releasing the adhesions using a thunder beam. We evaluated the length of the colon available for a pull-through and the vascularity using ICG. Then we proceeded to insert a 10 mm port through the perineum that was at our proposed new anal site. And then we were successfully able to pull down the colon and we did anastomosis. So this patient was able to tolerate oral feeds quite well by post-operative day 2. and she had a successful bowel movement by post-operative day 4. In conclusion, we can say that laparoscopy is appropriate for colonic pull-through even in patients who present to us with prior operations, whom we might assume that they might have a lot of intraoperative adhesions that we might encounter. And laparoscopy itself is helpful for us in dealing with the difficult pelvic dissection, where access by laparotomy can be said to be limited. Thank you.
Can I ask a short question? You use a stimulation to see where the muscle complex is from outside. Do you sometimes do it from the inside as well to see the muscle complex intraabdominally before we put the trocar?
We usually check it from the outside.
Stay on the stage. From the same team, we have the next paper, retrospective analysis of laparoscopically managed pediatric patients with Hirschsprung disease. Can we have the next?
Thank you. Our study is a retrospective analysis of laparoscopically managed pediatric patients with Hirschsprung disease. It was a single institute review of 28 patients from 2016 to 2022. We basically took up these patients for laparoscopic surgery, in which the major steps included obtaining the frozen section with multiple biopsies. We were mobilizing our bowel, again under guidance of ICG. We were able to divide the mesocolon to enable proper mobilization, and we pulled down the colonic loop. Then we proceeded for the coloanal anastomosis after circumferential dissection of the rectum. Out of our 28 patients, the mean duration of our surgery was 4 hours, with the median length of hospital stays seen to be 6 days. We find the advantages of laparoscopy in management of Hirschsprung disease to be as follows. We were able to successfully identify and eliminate any torsion of the bowel loop. We were able to utilize ICG successfully to verify the vascularity of our bowel loop. We were able to serially sample the bowel without having to wait for frozen section report. And we were able to mobilize the bowel up to quite long distance if required. That was all under vision. There was ease of obtaining the multiple seromuscular biopsies, and we also were able to have less perineal injury from anal traction. In all of our patients on follow-up, there were no strictures. We would attribute that to an oblique tension-free anastomosis that we performed. We were ensuring there was no torsion or ischemia intraoperatively, and we had kept every patient on regular calibration with a Hegar dilator on follow-up. So in conclusion, laparoscopy can be said to be safe, feasible with a good success rate, but we should ensure regular follow-up and adherence to a Hegar dilator in the patients. Thank you.
No questions? Anybody else doing regular dilatations after Hirschsprung's disease? Yeah. There was a question.
Wonderful presentation. No details about the technique you adopted really as a walkthrough, but why Hegar dilatation is mandatory? Because it's not really invasive practice, and it's very often made, but why?
We feel that post-operatively these patients can develop strictures. So we would find that keeping the patients on a regular Hegar dilator would help them would help us prevent them from developing strictures.
Thank you.
Thank you.
The next paper is from Prague, laparoscopic restorative proctorectomy with ileal pouch anastomosis for Gardner syndrome in children.
So, good evening everyone. Chairperson, Gardner syndrome is very rare inherited disease. It's variation of familial adenomatous polyposis. This case is about a girl who was examined by dentist because like eruption of definitive teeth. And also on the X-ray there was several stomas in X-ray in jaws. Because this findings, she was sent to genetic examination where they confirmed Gardner syndrome. She underwent another examinations, for example, among them endoscopic examination, coloscopy, where there was found several hundred of laparoscopically assisted restorative prostatectomy with pouch anastomosis. The procedure and postoperative course was uneventful, and conclusion is to have a good dentist, educated. No, but main conclusion is to think about this syndrome and to operate it laparoscopically and in one stage, because otherwise there is an increased risk of desmoid tumors intraabdominally in this syndrome. Thank you very much.
No questions? Thank you for taking time to move to the next paper. So we have, again from Bologna, Italy, Chiara Cordula, who will present public health assessment in adult females following pediatric appendicitis and motor syndrome, retrospective case control study.
Good afternoon. Okay, we have done this more sensitive retrospective case control studies to assess the pelvic health in patients that underwent operation in childhood for acute appendicitis. We divided the patients into groups. Group A, the patient that underwent operation for complicated appendicitis, and Group B, patient that underwent intervention for uncomplicated appendicitis. All the patients underwent open appendectomy because we take patients that now are adult, so that we can really evaluate the status. And then we have a control group of healthy volunteers that haven't had abdominal surgery except for C-section. What we find out is that there were no difference in number of pregnancies, miscarriage, and on the incidence of ectopic pregnancies and endometriosis. The only significant data that we found out is that the patients that were operated for complicated appendicitis has a higher incidence compared to the control group of chronic pelvic pain. It will be interesting in the future when the patients that now are operating laparoscopically grow up to see if this data decrease with the use of laparoscopy that can cause less adhesion, or if it will be the same because the pain is caused by the infection and not by the surgical procedure. Thank you.
Thank you. Any questions from the floor? No? Thank you.
We move on with the next paper from Budapest, Hungary. Appendectomy in children. Is it still questionable whether laparoscopy or oral?
Okay, good afternoon. Our aim was to evaluate the advantages of the laparoscopic against open appendectomy. This is a common question in our conference. So we performed a retrospective observational cohort study. We included the patients between 2011 and 20. We formed groups as laparoscopic and open appendectomy patients, and we divided these groups to subgroups by histological findings to uncomplicated and complicated acute appendicitis groups. We excluded all the patients who had any kind of comorbidities who needed surgery, and we investigated the parameters was the postoperative complications and the length of hospital stay. Our sample was less than 1,500 patients. The majority of them was open approach in this era. Our main result is that the length of hospital stay was significantly shorter in all the laparoscopic group, and we did not find any difference in the complications within open laparoscopic approach. So we can conclude that both laparoscopic and open appendectomy are safe methods in children with no difference in complications, but the length of hospital stay is significantly shorter in laparoscopy. Thank you.
Any questions from the floor? Can I ask you, you're a young surgeon, do you do open appendicectomy?
When I was training, I started to do in open approach because we didn't have enough laparoscopic boxes, and we switched in our department at I don't know, 2017 to laparoscopic approach when we bought so many laparoscopic instruments, and now it's obligatory to do via laparoscopy. But in the first wave of the COVID pandemic, we switched back to open approach. So it was very funny because the new trainees wanted to do open surgery because they cannot do open now only laparoscopy.
Okay, thanks.
The last day for our Congress is, does COVID-19 pandemic make a difference in pediatric appendicitis outcome from Poland?
Good afternoon. So when the COVID pandemic started, we all had an impression that patients started to present to us with a longer history of symptoms and generally speaking worse state, so we wanted to test this hypothesis. So we compared a year of pandemic, the first year of pandemic, with a year pre-pandemic. We took patients from two university centers in Poland, so we had more than 150 patients in each group. And shortly speaking, we did not find any significant difference in course of the disease or in complications. The only difference was shorter hospitalization, say antibiotics usage and higher laparoscopy rate, but that was due to the development of one of the centers that was included in the study.
That was the fastest one from the whole conference.
Yeah,
Any questions? Any questions from the floor? Thank you very much.
Thank you.
So this is the end. Thank you everybody.